Good afternoon. This presentation is on bipolar disorder. These are the following objectives: to understand the etiology and epidemiology of bipolar disorder, to know the diagnostic criteria of bipolar disorder and the diagnostic workup, to understand the acute and maintenance treatment of bipolar disorder, and to appreciate some of the controversies surrounding bipolar disorder. The outline of this presentation will cover the background of bipolar disorder, preliminary DSM-5 diagnostic criteria, evaluation and treatment of bipolar disorder, controversies surrounding it, and prognosis. So first, a scenario. You are the psychiatry resident on call, and a 25-year-old Chinese female university student comes to the hospital. She was brought to the A&E for being disruptive in class, praying over her classmates and trying to heal them. She has been noted to be gesturing and muttering to herself, frowning, then suddenly bursting out in laughter. She reports that she has not slept for 5 days, that she does not have time to sleep because she has to do God's work. She says that the Holy Spirit has infused her, and God has given her special powers, such that she has to help others so that the universe will be saved. She feels that her mood is very good. In junior college, she had been treated for depression but is no longer on medication. She denies any hallucinations or delusions of persecution or control. She also denies any suicidal ideation. Bipolar disorder was first described by Emil Kraepelin in the late 19th century and was previously known as manic depression. The lifetime prevalence is fairly stable across different countries at 1 to 2%. The gender ratio is equal in bipolar 1, but bipolar 2 is more common in females. The mean age of onset is around 17 years old. 1% of patients would have been wrongly diagnosed with unipolar depression in the past. Bipolar disorder has a high heritability, with a concordance of up to 70% among monozygotic twins, and the lifetime risk for relatives of the proband is 5 to 10%. There is also a link to other forms of mental illness, with an increased risk for schizophrenia in relatives of proband. There is little difference in diagnostic criteria between DSM-4 and 5. At least one manic episode is required for diagnosis of bipolar type 1, consisting of a distinct period of abnormally and persistently elevated, expansive or irritable mood, and abnormally and persistently increased activity or energy, lasting for at least 1 week, and present most of the day for nearly every day. If hospitalization is necessary, no minimum duration is required. There also needs to be at least 3 other criteria, or 4 if the mood is primarily irritable. This is commonly remembered by the mnemonic DICFAST, which stands for distractibility, indiscretion, grandiosity, flight of ideas, increased activity, decreased sleep, and talkativeness. For bipolar 2 disorder, at least 1 depressive and 1 hypomanic episode is necessary. Criteria for hypomanic episode is as for manic episodes, with the difference that symptoms have to last for at least 4 days, and that there is no psychosis, impairment in function, or hospitalization. The hypomanic episode should be associated with an unequivocal change in functioning that is uncharacteristic of the patient when not symptomatic, and the disturbance in mood and the change in functioning are observable. For mania, the episode should be severe enough to cause marked impairment in social or occupational functioning, or to necessitate hospitalization, or presence of psychotic features. Exclusion criteria include drugs, medication or ECT, or other psychiatric illnesses. Mania or hypomania emerging during antidepressant treatment, including ECT, but persisting beyond that is insufficient evidence for a manic or hypomanic episode. However, caution is indicated so that 1 or 2 symptoms that occur as a result of antidepressant use, particularly increased irritability, edginess, or agitation, are not taken as sufficient for a diagnosis of a manic or hypomanic episode, nor necessarily as an indication of a bipolar disorder diathesis. Differentials include psychiatric disorders like the psychosis, drug abuse, and personality disorders. Medical differentials to consider include thyrotoxicosis, seizures, autoimmune disorders, infectious disorders, and medication-induced. Workup includes a thorough history, which should be longitudinal rather than a simple cross-section of the current presentation. A physical exam should be done, focusing on neurological signs. Routine blood and urine tests, including a drug screen, should also be carried out. The decision for imaging or EEG would depend on the index of suspicion for other organic causes. According to the Canadian Network for Mood and Anxiety Treatment Guidelines, which were updated in 2009, mood stabilizers like lithium and valproate form the backbone of treatment of acute mania, although atypical antipsychotics like olanzapine, risperidone, and quetiapine are increasingly used. Second-line treatments include carbamazepine, asenapine, paliperidone, and ECT. We have effective medications for mania, but treatment for bipolar depression is lagging, with an overall response rate of only 30 to 50%. First-line medications include lithium, lamotrigine, quetiapine, and other combinations. If these fail, valproate and other combinations can be considered. For maintenance treatment, the recommendation is to continue the patient on the medication and dosage that brought him or her to remission. Hence, the first and second line recommendations are similar to that for acute treatment. For prophylaxis of depression, lamotrigine, quetiapine, or combination of olanzapine, fluoxetine have been found to be more effective. Psychosocial interventions like CBT and psychoeducation should not be neglected. Many medications used in bipolar disorder have the potential for teratogenicity. Valproate has the highest risk, with an almost 10% chance of congenital abnormalities, mostly neurotube defects. Carbamazepine can cause spina bifida. Lithium is famous for Epstein's anomaly, although the absolute risk is low. Lamotrigine has been found to cause cleft palate in some studies, although the strength of this is debatable. Antipsychotics and antidepressants have less evidence for congenital malformations. In mothers with bipolar disorder, there is an increased risk of pregnancy and birth complications even if the mother is treated. 1 in 4 mothers will suffer a recurrence, while almost 1 in 2 will develop postpartum psychosis. The decision on which medication to start, whether to stop medication before trying to conceive, whether to continue medication during pregnancy, needs to be individualized for each patient after weighing the risks and benefits. There are several controversies surrounding bipolar disorder. One is the diagnosis of bipolar disorder in children and adolescents. There has been a 40-fold increase in such diagnosis between 1994 and 2002, but there has been much debate about the reliability and validity of such a diagnosis. For example, whether a child diagnosed with bipolar continues to meet criteria in adulthood. What has been observed is that many patients are symptomatic before the age of 18. There is no clear consensus within the psychiatric community about antidepressant use in bipolar disorder. A manic switch has been observed with use of antidepressants, but the risks reported have varied widely. There is also no strong evidence of whether adjunctive mood stabilizers would balance out the switch. Finally, there is much discussion about subthreshold bipolar disorder. This includes hypomania without major depression or less severe hypomania in depression. This is estimated to have a prevalence of 2.4% and is associated with poorer response to antidepressants. The question is whether these patients would benefit from treatment with mood stabilizers, just like the bipolar population. The mean duration of treated mania is 6 weeks, while that for depression is 17 weeks. Bipolar disorder is responsible for significant disability. Only a small proportion of patients will remain substantially well in the long run. They experience depressive symptoms half the time, particularly in those with bipolar II disorder, and 50% will have recurrent episodes. Cognitive deficits have been found even between episodes when patients are euthymic. 2/3 of patients will have a comorbid psychiatric diagnosis, which is associated with poorer outcome. The risk of suicide is significantly elevated over the general population. 20 to 50% will attempt suicide at least once, mostly while in depressed or mixed states. And 15% of severely ill individuals will die by suicide. In summary, bipolar disorder is a disabling chronic psychiatric illness with a relapsing remitting course that requires lifelong treatment. It is associated with significant impact on psychosocial functioning and an increased risk of suicide. However, as bipolar disorder is not progressive, patients can be well in between episodes, and a small proportion are highly functioning and productive when euthymic. Thus, it is imperative to diagnose early and treat aggressively in bipolar disorder. Unfortunately, our knowledge of how best to treat depressive episodes is still lacking, and much research remains to be done on both the etiology and treatment of bipolar disorder. These are a few of the key references that have been cited.